Hello, and welcome to the Roseman University Roadrunner Resource Series. I'm Brenda Griego, Roseman's Alumni Director, and I'm glad you could join us for this latest presentation for Roseman graduates. Momentarily, we'll be hearing from Dr. Stephen Lee, who will update us on the most recent drugs approved by the FDA. But before I introduce him, I have two quick housekeeping items. First, this presentation is being recorded, and it will be posted on Roseman's YouTube channel in the coming days. We will email you that YouTube link when it's available, along with a PDF of Dr. Lee's slides, which he is kind enough to share. Second, following Dr. Lee's 50-minute presentation, there will be a 10-minute question and answer period. To submit a question, please click the Q&A icon at the bottom right of your screen. Dr. Lee will respond to your questions in the order they were submitted. And now it's my pleasure to introduce Dr. Lee. Dr. Stephen Lee joined Roseman University as an associate professor of pharmacy practice in 2014. Prior to that, he was an associate professor at Ferris State University in Michigan. He received his master's degree and his PharmD from the University of Florida and was a biological scientist with that university prior to starting his teaching career. And now, take it away, Dr. Lee.
Thank you, Brenda. Good evening and welcome. It's my pleasure tonight to have the opportunity to join everyone for this session. So I'm really appreciative of this opportunity. My topic for today is the new drug update for the year 2020. Oops, let's see. So at the end of this presentation, I hope the audience members will be able to identify the medications that received the US FDA approval in the year 2020 and to discuss the indication and the key features of the selected medications here. And a couple of disclaimers here. Number one, I have no financial interests or relationships to disclose, but I'll definitely let you know the moment when I made it that big. Secondly, we are focusing only on the new agents. So if there is a new formulation or new indication that was FDA approved for an existing drugs that's already on the market, we will not be discussing those tonight. So yes, even though tramadol has got a new approval for an oral solution, that is not going to be within our scope this evening. Thirdly, I don't claim to be an expert in any of these. I do not. But I'm always interested in new drugs, and it's always fascinating to me to get to learn about the new drugs and what they can do for our patients. And lastly, I just want to thank all the Roseman University alumni, because each one of you is going out there trying to make the world a better place for all of us. So I appreciate the opportunity, and I hope that I can help you present some information to you this evening, and I hope that you will find it enjoyable. So what is new this year in 2020? Well, in neurology, we have a couple of new medications that has become available to us. We have Rimegepant, which is an acute treatment for migraine headache. And we also have Monomethyl Fumarate, which is another treatment option for multiple sclerosis. But throughout this presentation, you'll find out that actually many of the exciting things actually came the year before. So therefore, we're going to be talking about some of the drugs that are approved, prior to this year, because many of these newly approved medications are related to those medications from 2019. And then there's also a new medication for Parkinson's disease. And then in the world of infectious disease, there's a new HIV medication, but this is intended and approved for patients that are very treatment experienced. And then there's also a prescription-only medication for head lice. Then over in the arena for hyperlipidemia or cholesterol, we have bempedoic acid. And we also have an androgen receptor antagonist that's a topical preparation for dermatology, and as well as a couple of medications for anesthesia or procedural uses, such as a medication for procedural sedation, as well as for postoperative nausea and vomiting. And then lastly, there's also a new medication, oliceridine, which is for pain control, but it's only available as an IV. So we're going to touch base on many of these medications this evening. Let's start with migraine headache. Migraine headache is considered to be one of the primary headache types, and other types that are considered to be primary headache includes tension headache as well as cluster headache. These primary headaches are usually the headaches that are not attributed to other causes. In other words, for example, if the patient has a brain tumor or something like that, then and they have developed a headache, and those in that particular case here, the brain tumor related headache will not be considered a primary headache. And typically for migraine headache, it is usually considered to be an intense throbbing or pulsing pain, typically in one area of the head. But you and I might have patients that have talked to us about not only do I get headache on one side of my head, I might also get headache on two sides of the head or in alternating fashions too. So that those do happen. But regardless, though, the migraine headache typically lasts anywhere from 4 to 72 hours. And classically, when we think of migraine headache, we think of migraine headache as the headache with the aura. And the aura is some kind of sensory phenomenon or visual disturbance. The patient might start seeing images that are distorted. They might see flashing lights. They might see a zigzag line in front of them. And then typically these type of aura develop gradually over 5 minutes and can last up to 60 minutes. And during this time of the aura, this is when the headache may occur, or the aura might stop and then the headache begins. But there are also times that the headache may not occur after the aura. Then of course, there's another group of migraine headache, which is the headache without the aura. And that gets a little bit trickier in terms of identifying the symptoms. So what we know about migraine headache at this point is related to the trigeminal nerve. The trigeminal nerve, upon its activation, could release a peptide called a calcitonin gene-related peptide, or CGRP. The CGRP can then interact with its receptor on the blood vessels, and we believe that this blood vessel interactions with the CGRP is one of the reasons why migraine headache can develop and propagate in an acute episode. And as you can see, this is where some of the medications that we'll be talking about is going to be working on. So when we look at treatment for migraine headache, typically we look at two types of treatment. The first one is the abortive treatment, and the second one is the preventative treatment. But regardless, the patient should also practice the avoidance or minimization of the triggers. And some of the triggers for migraine headache includes the menstrual cycle, stress, sleep dysfunction, as well as fatigue. And so for those reasons, the patient really need help, and hopefully we can do our best to help them to manage those type of triggers. But in the event that the migraine headache does occur, then abortive treatment is offered to the patient. And some of the examples are listed here. Very commonly, we defer to medications such as the triptans, which are serotonin receptor agonists. And these are the cornerstone of therapy for migraine headache. Unfortunately, however, these medications also have some issues when it comes to side effects, ineffectiveness, and contraindications. A new medication called lasmiditan has recently been FDA approved, and it's supposed to be an alternative to the triptans, and we're going to talk about that shortly. But very commonly, patients that receive a triptan for migraine headache also receives an NSAID, such as ibuprofen, and often too, the patient might also receive an antiemetic, such as metoclopramide, in combination with the triptans, and sometimes even with the NSAIDs, to try to abort the migraine headache. Other options are available, such as the combined analgesics, as well as the ergot alkaloids. But this is where the exciting new discoveries are available to us. The calcitonin gene-related peptide is involved in migraine headache. And so if you can find ways to antagonize their effect, we should be able to control the migraine headache. And this is why this group of drugs called gabapents, such as ubrogepant and rimegepant, are recently become available for clinical use in the treatment for migraine headache. And in patients that cannot receive the abortive treatment, or if they have frequent recurrences, then some of the other medications, such as the antiepileptic drugs, calcium channel blockers, beta blockers, tricyclic antidepressants, amongst other things, could also be used. Botulism toxin injection is also another option there. And this is where things are also interesting too, because the same target, the calcitonin gene-related peptide antagonist, can potentially, actually can also be used for prevention, but not in the form of the pills that we saw earlier, but in the form of an injectable monoclonal antibodies, or the MAPs. So here's a overview of some of the triptans. As you can see, most of them are available by mouth, but some of them also has the nasal injection, or as well, the nasal route, excuse me, as well as the injection routes there. And then the Ditan, which is a new class of drug that was FDA approved last year, it's available as an oral dosage form too. So how these drugs work is a little bit different. We know that the triptan acts on the serotonin 1B and 1D receptors. And upon acting on these receptors, the release of the CGRP is reduced. And hopefully in the process, the migraine headache can be aborted. However, these drugs also trigger vasoconstriction of the blood vessels. And that's why these medications are not recommended for individuals who are at high risk or already have episodes of myocardial infarction or stroke. And this is where the excitement for me as a pharmacist is coming in, because if you look at the new medications, the Ditans, for example, work on the serotonin 1F receptor that can also try to reduce the release of the CGRP without a very significant interactions on the blood vessels there. And then the gapans, the drugs that we're going to be talking about this evening, work directly on the receptor to block the CGRP from interacting with the receptors. And this is also the same place where the monoclonal antibodies can work to block the receptor. But we also have monoclonal antibodies that can block the CGRP directly without necessarily going through the receptor. So let's start with the oral agents here. The oral CGRP antagonist includes the two medications, rimegepant as well as ubrogepant. Rimegepant was the one that was FDA approved this year. Ubrogepant came a little bit earlier last year. And rimegepant, or Nurtec, is available as an oral disintegrating tablet, and the dose is 75 milligrams once by mouth as needed. But the patient should not be taking more than one dose in 24 hours. On the other hand, in the case of ubrogepant, the patient can take a second dose after 2 hours of the first dose. Some of the pharmacokinetic parameters are listed here. As you can see, the metabolism involves the CYP enzymes. Elimination in the case of rimegepant involves feces and urine, but mostly in the feces by ubrogepant. But in both cases, the patient's dose should be adjusted if they have a creatinine clearance estimated to be less than 15 milliliters per minute, or if they have severe hepatic impairment. So in the case of ubrogepant, that would be, the drug should be avoided in patients with severe hepatic impairment. But in patients that have severe impairment here, then they can reduce the dose to 50 milligrams. And patients also with creatinine clearance less than 30 milliliters, but more than 15, should also have their dose reduced too. Both drugs are indicated for the same thing, which is for the acute treatment of migraine headache with or without aura in adults. You do have to watch out for hypersensitivity risk with rimegepant there. Side effects wise, nausea seems to be the one that stands out, whereas in the case of ubrogepant, we see nausea and somnolence or sleepiness. Counseling for the patients includes the telling the patient not to remove the drug from the blister pouch until they're ready to use. But in the case of ubrogepant, we do have to watch out for the grapefruit juice and more drug interactions, as well as the pregnancy and lactation issues in the patient. So how effective are these drugs? So if you look at the phase 3 clinical trials, in the case of rimegepant here, about 14% of the patient was on preventative medication, whereas the number is a little bit higher when ubrogepant. We're looking at the drug versus the placebo here. And what do we see? The first endpoint, which is pain-free at 2 hours from the migraine headache, as you can see there, rimegepant had about 20% of the patient that was pain-free at 2 hours, compared to about 10% for the placebo group. And we're seeing the numbers that are somewhat similar in different studies for Ubrogepant. And then the second endpoint, which are often commonly investigated on, is the relief or the most bothersome symptom free at 2 hours. So in this case, we're looking at about 35% for Rimegepant, and for Ubrogepant, the numbers are comparable. And then lastly, it is possible that patients that have received the medication may not be pain-free, but they have pain relief, so the pain is not as severe. So in that case, what are we looking at? So as you can see here, we got about 60% versus 43% in the case of Rimegepant, and the numbers are, again, quite comparable with Ubrogepant. So overall, as you can see, these drugs seems to be effective, and the adverse effects doesn't seem terrible. So these are probably safe to say, safe and effective options. And what about for the preventative drugs? So we're looking at the monoclonal antibodies there, and they include Ianalumab, which is the commercial name is Aimovig, as well as a couple of others such as Firmanizumab, Aptinizumab, as well as Galcanezumab here. They're all indicated for preventative treatment, except in the case of Galcanezumab, it's also indicated for cluster headache. And their mechanism is fairly similar. They all work on the CGRP, but Ianalumab works on the receptor antagonist, as a receptor antagonist, whereas in the case of the other three, they are working on the ligand directly. And the route of administration includes subcutaneous for most of them, but one of them is given indeed by intravenous injection. So I personally feel that the gepants offer efficacious and safe treatment options for patients with migraine headache without necessarily the cardiovascular concerns with the triptans. So now we have options for patients who may not be candidate for triptans, who could not take triptans because of comorbid conditions, or we also have options for patients who the triptan did not work very well, and now we can try to offer them something else. And I wish I can give you more data in terms of how these drugs compare to the triptans, but the data from direct head-to-head comparison is very limited. So far, we do have one study that looked at triptan versus one of the CGRP receptor antagonists for abortive treatment, and it does look like the triptan seems to be a little bit more effective. However, I must stress that this study was not intended to be a direct comparison. And so this is sort of like, what we observe from a study there. So this statement of triptan being more effective, should not be taken as a well-established fact. There's much more work that needs to be done for us to really come to the conclusion that is triptan better or worse than these gepants. And the other question that I have is CGRP does a lot of things within the body. So by blocking CGRP, what else could we be doing? And that's the part that we don't know, but there will be something that we'll learn more in the near future, hopefully. And then Lasmiditan, which is Rayvow, it's also FDA approved now from 2019. It's also providing another alternative to the triptans. The result seems to be comparable in terms of the abortive effect for migraine headache. However, there are concerns with dizziness, somnolence, and drug interaction. And the 8-hour rule for Lasmiditan needs to be observed, which is when the patient receives Lasmiditan, the patient should not be driving or operating heavy machineries for 8 hours. Now, I suppose that's probably not a big deal if the patient took this medication at 9 o'clock at night and ready to go to bed. But on the other hand, the patient took this medication at 8 o'clock in the morning, then the whole day might end up being lost because of the medication effect. So I do think that it's exciting that we have new options for the treatment for migraine headache, but these new agents all have their unique features. And I think it's really a good thing that we have more options so that people can have more choices. Moving on to multiple sclerosis here. So multiple sclerosis is an autoimmune disease of the brain, specifically the neurons, where the lymphocytes or the cells in the immune system attack and damage the myelin sheath of the neurons. There are multiple subtypes. The most common one, based on the disease course, is the relapsing remitting type of MS or RRMS, which accounts for as many as 80 to 85% of the patient. And in these particular type of patients with RRMS, there's a clearly defined attack, and the patient often would have some kind of recovery or remission. However, the rest of them are not necessarily so kind. The primary progressive, secondary progressive, and the progressive relapsing form of MS are all MS forms that would continue to progress, and therefore the patient's disability as well as other comorbidities could progress with it. And lastly, let's talk about a clinically isolated syndrome, which is the first episode of neurological symptoms that last over 24 hours. This is often considerations too for patients with MS. And because the neurons that are being attacked could serve different functions and control different body parts, the signs and symptoms of MS is highly dependent on the affected neurons in the area. So for that reason, patients with the same diagnosis of MS might have different clinical presentations. So what we have here is a list of all the treatments that have been made available to us in the US. Initially, in the early or more like mid-1990s, we have the interferons. And then later on, we have glutathione. And then we have other medications, but as you can see, most of them are available only in the form of parenteral administration. It wasn't until this decade in 2010s that we see the oral agents. The first one is fingolimod, followed by teriflunomide, diroximel fumarate, as well as dimethyl fumarate. And then last year, we have siponimod and ozanimod. And this year, we have monomethyl fumarate. And in the near future, hopefully, we get to talk about other options, such as ofatumumab, as well as ponesimod. Now, I'm going to be very frank. Monomethyl fumarate sounds a lot like dimethyl fumarate, doesn't it? Well, it turns out dimethyl fumarate, when taken into the body, is going to be converted by the body into monoethyl fumarate. So that's really not a whole lot to talk about. But I think the excitement really comes from medications that came prior to that, which is siponimod, ozanimod, as well as ocrelizumab. So that's what we're going to spend some time on. So as we said earlier, monomethyl fumarate, or MMF, is FDA approved this year. It is shown to activate what's called the NRF2 pathway, or the nuclear factor erythroid-derived 2-like pathway. And what this pathway does when it's activated is to enhance the neuronal survival, so the neurons that are being attacked would survive better, and also protect the protect the glial cells, which are supporting the neurons against the oxidative stress. And we also could see the improvement and preservations of the myelin, the axon, as well as the neurons. Dimethyl fumarate, or DMF, is metabolized into MMF. And the approval of MMF is actually based on availability studies in healthy individuals compared to the oral form of DMF. So really, this is just these two drugs are very similar to one another. But siponimod and ozanimod, which was FDA approved earlier last year, are quite interesting. They're both indicated for the relapsing form of MS, including also the patient with clinically isolated syndrome as well as the RRMS and the secondary progressive form of MS. These drugs are all belong to the sphingosine-1 phosphate receptor modulator. So what is it? Well, this sphingosine-1 phosphate is going to act on receptor type 1. And what we know about this receptor is that when this receptor is activated, it's going to promote the lymphocyte trafficking into the brain. And as you remember, multiple sclerosis involve the lymphocytes trafficking into the brain and attack the neurons. So if there are ways that we can block the trafficking, we should be able to help patients with MS in terms of having less autoimmune attack by these lymphocytes. The original compound, fingolimod, is intended to do such. But fingolimod also acts on 3 of the 5 known receptors in the sphingosine-1 phosphate receptor system. And so fingolimod does accomplish the reduced trafficking, but unfortunately, it also has activity on the IL-3 receptor as well as IL-4 and IL-5 receptors. And what we now know is that the IL-3 receptor is involved with the cardiac conduction disturbances. So that's why when patients take fingolimod, there's quite a bit of preclinical work that pre-dose work that needs to be done for these patients receiving fingolimod. Siponimod and ozanimod are supposed to target more on the R1 and the R5 receptors, but as you can see, they do also have some cardiac disturbances. But what we don't know is whether or not these cardiac disturbances came from these drugs working with the IL-3 receptor or some other reasons. So in the case of all 3 medications, the FDA did not issue any black box warnings, which is good. However, there's quite a bit of contraindications to consider. So patients that have heart AV block, sick sinus syndrome, in other words, some kind of bradycardia or bradyarrhythmia, as well as myocardial infarction, unstable angina, stroke or transient ischemic attack, or severe cases of heart failure, such as those patients have the class 3 and class 4 heart failure in the New York Heart Association classification system, or patients that have hospitalization within the last 6 months should not be receiving this medication. And in the case of siponimod, it's also interesting is that the patient has to have undergone a pharmacogenetic testing. In other words, the patient's gene has to be tested, not for the targets, not for the receptors the drug intended on, but for the metabolizing enzyme. So in this case, the CYP enzyme 2C9. And if they have the mutation of the STAR3 type, then the patient cannot be receiving siponimod. In the case of ozanimod, another 2 contraindications are if the patient has untreated sleep apnea, as well as a concurrent use of the MAO inhibitors, then the patient should not be receiving ozanimod. Other warnings for these medications includes infections, which is sort of expected because after all, these are immunosuppressive agents. But in the case of fingolimod, we did see some macular edema, liver toxicity. So those were, again, listed as warnings for these drugs. And in addition, there's also respiratory effects, such as a reduction in the pulmonary function test, elevated blood pressure, as well as the risk for the fetus. And other warnings includes bradyarrhythmia and atrioventricular conduction delays for siponimod and ozanimod. But for fingolimod, there are other things such as progressive multifocal leukoencephalopathy or PML, posterior reversible encephalopathy syndrome or PRES, amongst other things. And as anybody who work in the medical field would know, these 2 things are unpleasant and it can be fatal. So we have to be concerned with these medications, with the medications that are associated with these type of conditions. In addition, there's also worsening of multiple sclerosis when the drug is stopped. And there have been reports of patients developing skin cancer. Granted, it's only a very small number, but it's something that as healthcare providers, we need to be looking out for. So when it comes to the doses for these medications, they're all taken by mouth, and I've listed the doses here. Siponimod is a tablet, whereas the rest are capsules. Metabolism is also going through the liver as well as through the CYP enzyme systems there. And then we also can see some metabolites being formed. And the elimination for siponimod and for ozanimod are through the feces, whereas fingolimod and its metabolites are eliminated through the urine. Now, the dose is very interesting. Fingolimod, the first older drug, was dosed based on the patient's weight. Ozanimod, on the other hand, requires a titration schedule. The first 4-day patients received the 0.25 milligram dose, and then the next couple of days they receive a higher dose, and then on day 8 or after they receive the highest dose. But siponimod gets a little bit interesting here. The dosing is dependent on the CYP2C enzyme system in terms of the genotype. So from genetic testing, if the patient carries the STAR3 mutations, then the patient cannot be receiving this drug. On the other hand, if the patient only has one of the STAR3 mutations, such as if they have the genotype STAR1 STAR3 or STAR2 STAR3, then the dose the patient should be receiving would be 1 milligram. And here's a titration schedule for that. On the other hand, if the patient does not have the STAR3 mutation, so all the other genotypes, then the patient's target dose will be 2 milligrams. And as you can see, the titration schedule is listed here. In this particular case, the titration schedule is going to take a little bit longer by day. So this is where things get really interesting. Before the patient receives the medication, in all 3 cases, the patient should have a complete blood count, liver function tested, their current medication should have been evaluated, and vaccination against varicella-zoster virus or shingles should be evaluated and considered. Additionally, in the case of siponimod and ozanimod, the patient should receive an ECG or electrocardiogram, as well as an ophthalmic evaluation. And of course, because of the dosing and the concerns with the CYP2C9 enzyme, siponimod requires the patient to have a genotype testing done. Whereas in the case of fingolimod, it just says cardiac evaluations in the prescribing information. What's to me very interesting is after the patient received the first dose, guess what? In the case of fingolimod, the patient has to be in a setting with cardiac evaluation, so probably not home. So in this case, realistically, the patient might be admitted into a facility for observation purposes, and the patient has to stay overnight and receive continuous ECG monitoring just to make sure there's no the cardiac disturbances there. Whereas in the case of siponimod, after the patient receives the medications, the patient should be in settings with cardiac evaluations, but only for those patients with sinus bradycardia, heart block, or history of myocardial infarction or heart failure. And in the case of ozanimod, none of those is required. And there are also very specific instructions in terms of if the patient's medication dosing is interrupted. In other words, if they miss the dose or if they miss a couple of doses, what do we do? So there's also specific guidelines in terms of when to reinitiate these medications with the escalation schedule there. So how effective are these medications for MS? Well, if you look at siponimod, the clinical endpoints and the studies that were done were a little bit different because the primary focus for siponimod studies was really looking at slowing down the progression there. So, but as you can see, for these medications here, the annualized relapse rates as well as the number of lesions on an MRI are the primary focus. And these numbers overall, looks kind of comparable to the other two. The other two medications, ozanimod and fingolimod, the clinical trial were done with different controls. So in the case of ozanimod, it was compared to beta-ferrons, and there are actually 2 studies. One study is for 1 year and the second study for 2 years, excuse me, not the second year. And in that case, if you look at the annualized relapse rates, we're looking about 50% reduction and 48% reduction in the second year. And overall, we see about 77% patient without relapse. And the number of lesions has dropped also by about half to about 60% for the T1 lesions. And for fingolimod, the numbers are comparable. The relapse rate is about 45%, 70% of patients without the relapse, and then but the lesion number are not as impressed as the ozanimod here. So efficacy-wise, these medications seems like they can reduce the relapse and to reduce the number or the size of the T2, T1 lesions as determined by MRI. And these are typically the endpoints that are studied for drugs for MS. So how do these drugs help patients with their different levels of disability or pain or other things, for example? Well, unfortunately, those are not very well studied in these particular studies that were reported. But what we do notice is from the side effects. And not surprisingly, you can see that, infection is quite common with these medications. But in the case of fingolimod, we see more liver enzyme elevation compared to the other two. There's more pain in general and more gastrointestinal symptoms. And like I said, there has been cases of skin malignancies reported or skin cancer. However, in the case of siponimod there, we see more hypertension and bradycardia. Ozanimod does have some of these side effects, but overall does not look unacceptably bad. So that's nice. We have two new medications that are given the oral route. But if you take a look at ocrelizumab, which was initially FDA approved in 2017, it's also very interesting when you start looking at these results. Now, I fully acknowledge that these drugs are not done in a head-to-head under the same clinical trial conditions. So comparing the numbers from one trial to another is not the best way. It's not the most reliable way, but it is nevertheless something that we can take a look at just to get an idea. So ocrelizumab or Ocrevus is a monoclonal antibody that targets the CD20, which is specific for the B lymphocytes. It's indicated for the relapsing form of MS as well as the primary progressive form of MS in adults. The dosing is initially 300 milligrams by the IV route, and then 2 weeks later, the patient received another 300 milligrams. But then 6 months later, patient received 600 milligrams. So in 1 year, literally during the first year, patient received 4 doses. And then in year number 2, now technically they just need to receive 2 doses. Compared to the sphingosine-1 receptor modulator, those have to be taken by mouth in the form of a tablet or capsule daily. And the clinical issues that we have identified so far include infusion reaction, and often the patient can receive a pre-medication with a corticosteroids well in combination with an antihistamine to reduce these infusion reactions, the risk of infection, and potentially the risk of hepatitis B virus reactivation. And in terms of efficacy results, it's really interesting. The drug was compared against beta interferon as a control for 2 years. The 2 studies showed that the analyzed relapse rates is comparable to the oral agents at about 46 and 47%. But 82% of patients did not have relapse, and the number of lesions are also, in terms of the reduction of the number of lesions, are also significantly higher. So I think fingolimod has been an accepted treatment option for MS, but it is very challenging for the patients when they have to receive this medication in a setting where they can do, the healthcare professionals can do cardiac monitoring there. These newer agents with greater efficacy specific for the receptor type 1 demonstrate similar efficacy and reduce side effects. And I think the part about the medication initiation burden that is reduced is significant. There are still some safety concerns with bradycardia, atrioventricular block, and macular edema too. And the efficacy and adverse effects are considered acceptable, so that's good. But ocrelizumab as an alternative treatment is also available, and in this case, it has less pill burden and there's a less restricted regimen in terms of what the patient needs to be doing. So I think the good news is we have a lot of choices now for MS, but the not so good news is choosing them might be difficult because each of these new options are not free of problems from their own. And then the third disease I like to talk about is Parkinson's disease, which is one of the more common age-related neurodegenerative diseases, and along with Alzheimer's disease is 2 of the most common neurodegenerative disorders that we see in practice. This is a movement disorder attributed to loss of the dopamine neurons here. So typically the treatment are offered for 2 purposes. The first one is to try to enhance the effect of dopamine system, either by supplying more precursor to the body so that the body can try to produce more dopamine. So that's in the form of levodopa and carbidopa. Or drugs are offered to patients that mimic the dopamine. So these are dopamine receptor agonists. But these medications, unfortunately, all have some of their challenges there. So many of the patients are often initiated on the levodopa and the carbidopa here. And historically, a third option would be to try to reduce the first group of drugs would be try to reduce the metabolism of the degradation of the dopamine. In other words, trying to reduce the breakdown of the dopamine. And that was done with entacapone. But the new medication, opicapone, is used for the same purpose by inhibiting the COMT enzyme. And this COMT enzyme is the catechol O-methyltransferase enzyme, which is involved in the breakdown of dopamine. And when we're talking about medication therapy for Parkinson's disease, we need to talk about the on time and the off time. On time is what we want, which is periods of adequate control of the Parkinson's symptoms. But the off time is troubling. And during the off time, that's when the return of Parkinson's symptoms. And the off time is usually occurring between the medication doses. And that's why sometimes you see patients taking their medications more than what's typically recommended. I remember a patient of mine actually take his levodopa carbidopa 6 times a day, and I thought it was excessive. But in my conversation with the patient, in my conversation with the prescribing physician, they were both okay with it, and the patient did not seem to have any adverse effect. So I was okay with it, but I definitely do not recommend. And I'm not giving you endorsement to say that, okay, it's okay to use these medications 6 or 7 times a day. No, I did not say that. But I do want to share that the off time is something, it's very troublesome. And these off time is often more common with patients with longer Parkinson's history, or they have taken longer periods of time of levodopa. And remember too, during the off time, other bothersome symptoms could also be occurring too. We think of Parkinson's as a movement disorder, so we see the freezing of the gait, amongst other things. But some other conditions, such as apathy and memory problems, can also occur too. So opicapone is the COMT inhibitor that's indicated as an adjunct treatment for levodopa and carbidopa in patients with Parkinson's experiencing the off episode. The dose is 50 milligrams by mouth at bedtime, and the patient should not have any food 1 hour before, 1 hour after. And the dose should be reduced 25 milligrams daily in patients with liver impairment. Patients should not be taking an MAO inhibitor or any history of pheochromocytoma, preganglioma, and other catecholamine secreting neoplasias there. So the clinical studies have involved about 60% males, 64 years of age, mostly Caucasian. They have the disease for about 7.7 years, and they have 2 years history of the motor fluctuations. And 82% of them also receive other medications in addition to the levodopa. As you can see in both studies there, compared to baseline, the medications does reduce the off time by about 1 hour. And, in terms of the on time, which for some reason this is not working, apologize for that. We also see a reduction, we also see an increase in the on time here. And the adverse effect we see includes dyskinesia as well as constipation, an increase in blood creatine kinase, hypertension, syncope, and amongst other things. So how does this drug compare to entacapone? In pharmacokinetic studies, we see that we have a more sustained and pronounced inhibition of the enzyme. And there's also an increase in bioavailability of levodopa, which is what we want. And then there's no head-to-head study, unfortunately. What I could find was a study that was looking at different doses compared to entacapone. So again, this is not a head-to-head, it's just looking at a dose escalation study here. But as you can see, the results of the 50 milligram of the opicapone versus the 200 milligrams of entacapone were quite similar. So I think overall, it is an acceptable option there. And the rest of them includes bempedoic acid for hyperlipidemia, which is also available in combination with ezetimibe. And this is for high cholesterol for patients with heterozygous familial hypercholesterolemia, or with patients who have established atherosclerotic cardiovascular diseases will require additional lowering of the LDL. But as you can see in clinical studies here, the ezetimibe can lower the LDL by 23 points in 23 milligrams per DL, whereas the bempedoic acid is only about 17. The combination does reduce it on top with 36 points, which could be significant in the right individual. And the dose is 180 milligrams daily by mouth with or without food. But there are issues with hyperuricemia, tendon ruptures, but these might be related to the concurrent use of the statins too, because we also see muscle pain, back pain, and elevated liver enzymes. The drug will study with the statins, which is good because this is where we see most benefit. But the doses of simvastatin and pravastatin should be reduced because of the drug interactions. And here are the rest of my drugs. That includes the topical anti-androgen for acne. That is Winlevi is the brand name. There's clascoterol, excuse me. And then we also have a lotion for head lice, but this one's only by prescription only. The new medication for HIV is taken by mouth, but it's only for treatment-experienced patients with multi-drug resistant HIV infection. And then a couple other medications for sedation. So this is for example, remimazolam is a ultra short-acting benzodiazepine for sedation. Amisulpride is available as an IV now for postoperative nausea and vomiting. But if you look at the drug closely, you might have seen that in some other countries, it was studied as an antipsychotic. And then olociridine is an opioid-like drug for surgical pain, and it's only given in an IV setting, in an IV formulation, excuse me. So most likely it's going to be in an inpatient setting. We also have a couple of new medications for oncology, so for cancer and neoplasia, and most of them, as you can see, fall into the kinase inhibitor groups, as well as the monoclonal antibodies group. And these particular medications are usually indicated for very specific subtype of patients. So the patient, for example, they might have some kind of breast cancer, and that has a very specific mutation. So in those cases, the patient may benefit from these particular type of the kinase inhibitors and the monoclonal antibodies. And as always, every year we have some drugs for rare conditions and diseases. And here's a list for you. And at this point, we are only looking at medications from January of this year to the end of September of this year. So, I kind of wish that we had more options for diabetes, for example, but not at this moment of time. Hopefully that will change. Lastly, just want to thank all of you for spending this evening with me. I hope that you find this presentation enjoyable. And I want to also thank a couple of people, my two colleagues, Dr. DeCervo and Dr. Whitaker, for taking a look at my slides and giving me some very valuable feedback. And I also want to thank many of my APPE students. So some of them helped me look at this medication, some of them chime in their thoughts. So for example, Dylan Lucas helped me on the bempedoic acid